All right, if you're a medical trainee, you know this feeling all too well. Your patient's kidneys are in trouble, the labs are throwing out all these weird, abnormal proteins, and you're staring at a major diagnostic puzzle. Well, today, we're going to put the pieces of that puzzle together and dive deep into the world of kidney deposition diseases.
So let's set the scene. You've got a patient with acute kidney injury, and their labs are showing a paraprotein, a monoclonal protein. The big million-dollar question is, what's actually doing the damage inside the kidney? That is the exact clinical problem we're going to tackle right now.
And at the very heart of this problem are the deposition diseases. It's basically a whole group of kidney disorders, and they're all caused by this abnormal buildup of proteins. Now, the first, and I mean most crucial fork in the road, is understanding how these proteins are deposited. Are they neatly organized into specific structures, or are they just a complete, jumbled, amorphous mess?
This slide right here, this frames our entire diagnostic approach. Think of it like this. Organized deposits, like what you see in amyloidosis, are like neatly stacked logs. The proteins form these very specific patterns, like fibrils. Unstructured deposits, on the other hand, are more like a pile of sand. The protein just kind of accumulates in this granular, messy way. Getting this one distinction down is the absolute key to figuring out what's going on.
So here's our game plan. We're going to start by breaking down the difference between myeloma and MGRS. Then we'll get into those organized deposits like amyloid, and after that, the unstructured ones. We'll wrap it all up with the real-world diagnostic pathway and, of course, some super high-yield takeaways for your exams and your rounds.
First up, myeloma versus MGRS. This is such a fundamental concept. Are we dealing with a full-blown cancer here, or is it a smaller but still incredibly toxic clonal cell line?
Okay, so here's the bottom line. Multiple myeloma is a cancer. It has very specific diagnostic criteria, the whole shebang with bone marrow involvement, anemia, high calcium. But MGRS, which stands for monoclonal gammopathy of renal significance, is different. With MGRS, you've got this B-cell or plasma cell clone that's pumping out a toxic protein, and that protein is directly wrecking the kidneys. But the clone itself, it's too small to be called myeloma. That R for renal is everything. The whole diagnosis hinges on proving that kidney damage.
And this right here perfectly illustrates that difference. Myeloma cast nephropathy is a condition you see only with multiple myeloma. Why? Well, because you need an absolutely massive, cancerous production of free light chains. These chains then just flood the kidney's tubules, they hook up with a protein called TAM horsefall, and they form these hard, obstructing casts. Seriously, think of them like cement plugs clogging up the kidney's entire plumbing system.
Let's walk through that. Step 1, the myeloma cells just go crazy, pumping out tons and tons of free light chains. Step 2, these little proteins get filtered right through the glomerulus, no problem. Step 3, once they're in the tubules, they meet that TAM horsefall protein and they stick together. And finally, step 4, they form these rock-hard casts that literally block everything up. The result? A super fast, super severe acute kidney injury.
And here it is. This is the lab value that should have alarm bells going off in your head. In myeloma cast nephropathy, the serum free light chain level is almost always through the roof. We're talking typically greater than 500 milligrams per liter. If you see a number that high in a patient with AKI, cast nephropathy needs to be at the very, very top of your differential diagnosis.
Okay, let's switch gears. We're now going to focus on that first category we talked about, the organized deposits, where proteins form these very distinct structures. This is where we find diseases like amyloidosis.
This table is incredibly high yield, so pay attention. First, notice the two types of amyloidosis, AL and AA. See how they both form those beta-pleated sheets and both stain positive with Congo red stain? That's what gives you that classic apple-green birefringence under polarized light. But the source protein is totally different. Monoclonal light chains in AL and an inflammatory protein in AA. Then you've got cryoglobulinemia and fibrillary glomerulopathy. They also have organized structures, but, and this is crucial, they do not stain with Congo red.
Let's just pull out cryoglobulinemia for a second, because it has a classic presentation you just have to recognize. So a patient comes in with a nephritic picture, blood in the urine, high blood pressure, kidney injury. They have this palpable purpuric rash, usually all over their legs. When you see this triad, your very next thought should be, I need to check for hepatitis C, which is a super common trigger for type 2 cryoglobulinemia.
All right, let's pivot now to the other side of our diagnostic tree. What happens when these monoclonal proteins get deposited, but they don't form those neat and tidy fibrils? Well, this is the world of unstructured amorphous deposits.
And the classic example here is monoclonal immunoglobulin deposition disease, or MIDD. In this disease, monoclonal light chains, and fun fact, here it's usually kappa chains, unlike the lambda chains you see more often in amyloidosis, they deposit in the basement membranes. But because they don't form organized fibrils, on electron microscopy they just look like granular junk. What's tricky is that on basic light microscopy, this can sometimes even look a lot like diabetic nephropathy.
So let's put these two right next to each other, because this is key. Both AL and MID can be caused by a monoclonal light chain, but how they look under the microscope is completely different. AL amyloid forms those organized beta-pleated sheets, and it lights up positive with Congo red. MID deposits are amorphous and will be negative with Congo red. That one single stain is often the critical test that tells them apart.
Okay, so we've covered a lot of pathology, but how do you actually work this up in a real patient in the clinic? Let's walk through the diagnostic pathway, step by step, from your first suspicion all the way to a certain answer.
It's a really logical process. It all starts with your clinical suspicion, a patient with some unexplained kidney injury or a ton of protein in their urine. Step 2 is getting those essential blood and urine tests, the SEP, UPP, and the serum free light chain assay. But to really truly know what's happening inside that kidney, you need step 3, the kidney biopsy. This is the definitive, gold standard step. And finally, once you've proven there's a monoclonal process in the kidney, step 4 is often a bone marrow biopsy, to go find and characterize the B cell or plasma cell clone that's causing all this trouble.
And I really want to pause on this point because it's so important. Kidney biopsy is necessary to make the diagnosis. You can find a monoclonal protein floating around in the blood all day long, but you can't just assume it's what's causing the kidney damage. The biopsy is the only way to prove the link, to connect the clone to the crime, especially in those MGRS cases where you're trying to justify treating an otherwise small clone.
All right, we've covered a ton of ground. Let's boil this all down. If you only remember 4 things from this whole explainer, make it these 4.
First, myeloma cast nephropathy is a renal emergency. It presents with acute kidney injury, and it's tied to those sky-high free light chain levels, over 500. And remember, this is a condition you see only with multiple myeloma.
Second, for MGRS, the kidney biopsy is absolutely everything. It is the crucial step that connects the dots between that monoclonal protein you find in the serum and the actual damage happening in the kidney. Without that biopsy, you can't make the diagnosis, period. Third, amyloidosis. Just remember the 2 main players that affect the kidney. You've got AL amyloid, which comes from monoclonal light chains, and you've got AA amyloid, which comes from chronic inflammation, like in rheumatoid arthritis or inflammatory bowel disease. And fourth, that classic clinical picture. You absolutely have to suspect type 2 cryoglobulinemia when you see that triad of kidney disease, a palpable purpuric rash, and a history of hepatitis C. So we'll end on a forward-looking question. As our therapies for these plasma cell disorders get more and more targeted, how critical do you think it's going to be to make that fine distinction between MGRS and overt myeloma as early as possible? It's something to think about, and it really highlights just how important this pathology is for the future of patient care. I really hope this explainer helps you out on your next rotation. Thanks for tuning in.